non-surgical procedures and functions of Medical Reviewers Scotland Bill. Our second panel comprises representatives of the cosmetic procedures industry, and I welcome to the committee Leslie Blair, Chief Executive, British Association of Beauty Therapy and Cosmetology and Confederation of Beauty Therapy and Cosmetology, and Victoria Brownlee, Chief Policy and Sustainability Officer, the British Beauty Council. And we'll move straight to questions. And Emma Harper.
Thank you. Thanks, Convener. Good morning to you. So you may have heard some of the first panel in responses to the questions that we have. This is our first evidence session. So I'm just going to open it right up and ask you what your views are on the proposed model of regulating non-surgical procedures as set out in this bill for Scotland.
I welcome it as a starting point. I think that for it to be successful, it does need obviously a bit more bones about it. In order, if we're going to do it, we need to do it right at this stage to get some sort of oversight in our industry. I think so. If you would like me to go into deeper, I will, or I'll let Victoria talk now. But just like as a starting point, I think it's very, very welcomed in our industry. It's needed in our industry. We're in a ever-evolving industry. Things are changing so very, very quickly. It's very difficult to keep it up. I think things have gone quite askew over the last number of years, and it is very, very welcomed, I think, especially from governing and regulatory bodies, that we have some sort of oversight in place.
I pretty much second that. So Leslie's been working on this for many more years than I have, probably since the Kira review in 2013. But we, as the Council in particular, have been working on regulation in this space since we were started about 6 or 7 years ago, and have been working really closely with the UK government in a lot of the work that they've been doing in that space. So we absolutely welcome regulation in aesthetics, non-surgical cosmetic procedures, as I feel that it's essential for professionalising and raising the standards and reputation of the industry.
And what role do you think that Healthcare Improvement Scotland or other industry bodies have in setting up safety standards for practitioners who are, needing to be trained and regulated and supported?
Well, I think that we need, as I said previously, we need the oversight there for us all to adhere to. I think Health Improvement Scotland obviously is predominantly for healthcare professionals. I think we're needing some sort of licensing model for non-healthcare professionals, because that's very, very important, and that takes up a lot of the treatments and modalities that are being performed on a daily basis. So I think it's just important to set it up so that we get some parity there. That I always believe that everyone should stay in their own lane and work to their own capabilities and their own qualifications that they have, etc. But I think that we need this oversight there. I think a lot for consumer awareness. Consumers don't know what they're asking for. They don't know what they're looking for, a lot of them anyway. So I think sometimes we need something there that is going to educate the consumer and to educate everyone out there as well, and to give people something that they know that is going to be followed, and that's from the consumer to know where to go, and from the practitioner to know what they should be doing and what they shouldn't be doing as well.
I think the accessibility of the treatments that we have now has made it somewhat more of a frivolous procedure than perhaps it had been seen maybe a decade ago. So therefore, regulation and oversight from someone like Healthcare Improvement Scotland is really vital to hit home that the fact that these are risk procedures. There is a risk of complication, there is a risk of things going wrong, and so you need those mandatory standards in place, one, to check the practitioner is actually fit for fit in terms of standards, training, competency, but also that the premises themselves are safe, hygienic, that the person going to have the treatment knows that they've been inspected, and that there is recourse essentially if something should go wrong. And what we have at the moment is a system where, unless you're a healthcare practitioner, you do not have that for the vast proportion of non-healthcare practitioners are often offering these kinds of treatments as well.
And we have no accountability for the non-healthcare professionals, so there is no recourse if something goes wrong. If you're a healthcare professional, you're accountable if something goes wrong. You can be struck off from your association, etc. Non-healthcare, that's not the case. So we would like to see that as well, and that is going to raise the standards within the industry as well.
Okay, and just to touch on that, I know there's a hierarchy of procedures from non-invasive to more invasive. Yeah. Over the weekend, I read about someone who the eyebrow wax was so hot, and it should not have been applied to the skin, but it caused burns to both of the person's eyelids. Yeah. And so, you know, as a former operating room nurse, we would check the temperature of the water that we were going to use, or the saline for irrigating an open abdomen, for instance. And so they had processes in place. Yeah. And so I'm interested in the whole consent process of risks, benefits, alternatives, absolutely. Then the documenting of that, and then and it might be touching on other people's questions, but the whole tracking of that kind of conversation in order to make sure that consumers are aware of what it is they're accessing when they're accessing treatment.
Yeah, I think I'm really glad you brought that up, Emma. I was a practising beauty therapist for over 30 years. I just stopped just before COVID, just because other work gets in the way of it, unfortunately. But it's very, very important, and to go through the proper qualification and regulated qualifications. I know we were talking earlier about some accredited training against regulated qualifications. I'm very, very much for regulated qualifications, because I think there's a benchmark there to national occupational standards, so then we can be assured of the quality of the actual qualification given, because there is that examiner or the examination at the end that we are reaching that national standard. I think that anyone who has done that should know, let's use the waxing, that if somebody, when they came to me, I would go through a thorough consultation with them to make sure they are not taking any or using any retinols, that they're not taking Racetane, because all of these things would cause like skin thinness, blah, blah, blah. And I would document everything on the consultation. I would test the wax on myself. I would test the wax on the client. I would have the client sign the consultation to say I've done all of this. That's very, very important to have all this there. Now, as an insurance company, which we also are as well, that is part of our code of practice and good practice guide, that you must do this prior to treating the client and on every single visit. But let's be honest, how many times have you had that when you go to have treatments done? I go to places and it doesn't happen. I've got to ask for it to happen as well. So this is very, very important. And I think this is where the bodies like of ourselves and British Beauty Council, we can be out there educating our members and educating the industry. And that's what we do on what is good practice there. And that's what we try and do every single day.
Mm-hmm. Final question, Convener. Just what effect do you think this bill will have on the reputation of the aesthetics industry?
I hope it raises it. I really do, and it needs to be raised as well, because we spoke earlier about Wild West charlatans that are out there. It's happening all over the place because of how quick the industry is moving forward. It has been allowed to get there, but that isn't a reason for us to leave it there and to allow it to continue. I think we've now got to step in and make sure that the standards are there. There's lots of questions, there's lots of different research we're all going to have to do, etc. But it's just so, so important. And I think that the majority of professional, regulated, qualified people are absolutely welcoming this with open arms.
Mm-hmm. Yeah, I would agree with that. I think it's absolutely welcomed. The bill itself, I think, is quite thin. It would be good if there was much more around training, education, supervision and oversight, a little bit more tightness around the type of healthcare practitioners that can be regulated to be able to supervise and oversee people having treatments in their premises. In the UK regulation, for example, it's simply only the NMC, the GMC, the Nursing and Midwifery Council, and pharmacists and dentists. There's quite a substantially longer list of regulated healthcare regulated organisations that are allowed within this regulation, which I think is probably too broad for what we're talking about. Because ultimately, we want a person supervising or the person that's overseeing it to be trained in the modality and have deeper knowledge and understanding of the modalities that they will be supervising.
Okay, thanks. Thanks, Convener.
Sajid Gohani.
Thank you, and just declaration of interest as a practising NHS GP. Thank you very much for appearing today. I think, Victoria, given what you've just said, we were asking exactly the same questions about the bill in private to find out why this list of regulators were the case that it was. But I'm very interested to know, to speak a bit further about consumers and what they don't know. So when they go before a doctor, in a GP practice or in hospital, you kind of know a standard of what you're going to receive. But when you go to the beauty industry, you don't. So things like your botulinum toxin needs to be in the fridge between 2 and 8 degrees. And vaccines do the same, but you have to prove the medical grade fridge and prove that this is the case. But that doesn't necessarily happen everywhere, does it?
Absolutely not. Just as a declaration of interest as ourselves as well, we have been very clear from the outset as a council that we only think the healthcare practitioners should be offering injectable procedures. So I'm completely with you and in support of the concerns that you have. I think we know that there are perfectly competent non-healthcare practitioners that are training, but we can't have the guarantee that that competence is across the board. And also when there are instances of adverse reactions to injectables, I don't feel that they have the competency and knowledge and availability of prescription-only medication to deal with complications should it be needed, to be able to deal with that as swiftly as is necessary. And so if we are saying that the risk to the public is the primary focus of this regulation, then absolutely we can't have non-healthcare practitioners touching injectables, in our opinion.
And just back to the point about consumer confidence and consumers knowing that they get a basic standard, if we have this regulation in place, will that ensure that reputable businesses that follow the code and do get inspected will do things like ensure that their products are kept at the appropriate environment, ensure that the people providing treatment have a basic level of competence?
I think it will come down to enforcement, and that's always the concern with all of these things. We can have the most robust regulation that there is, but if there's not adequate resource and funding given to really robust enforcement of this, then who's to say with that? We would very much hope that the inspection process, that the ability to educate the public through a public education campaign, which, as Leslie's rightly said, we would be absolutely supportive of being involved in, would educate the public of these are the kinds of things that you should be looking for when you are going to a premises. But the proof will essentially be in the pudding and the actual enforcement and enactment of this regulation when it comes in.
Just on premises, so we heard from the previous panel about people performing procedures at home in their garden sheds, or not sheds, sorry, pods.
Yeah.
And that would be put at risk. Now, in my opinion, if you are providing a procedure, you need to be doing that in an environment which is clean, the ability to wash your hands and have levels of hygiene, which is what his premises would provide. And you could still make that a comfortable, homely environment.
And let's not... I think there was some concerns I had with the previous evidence that was given around removal of livelihood. There are still hundreds of procedures that can be offered to consumers that people from levels, and Leslie, you'll be more knowledgeable for this than myself, levels 1 up to 4, 5, up to 7 can offer that aren't within Schedule 1. So, yes, there will be limitations to the procedures that non-healthcare practitioners can offer. No one's arguing that. But in our opinion, for public safety is number one priority. They shouldn't be doing those anyway, in our opinion, unless there would be very, very strict oversight in certain ones in the schedule, not necessarily all. So for us, the idea of them being done remotely, mobile, in pods in people's back gardens is completely against what it is that we're trying to do here.
And sorry, did you want to
comment?
comment?
I was just going to say, I think we're asking for parity and an even playing field from the beauty therapy side, but also from the medic side as well, that if medics, healthcare professionals have got to jump through hoops to have the proper ventilation, the proper cleanliness standards, just all of the things that is involved in being an HIS clinic, then it remains very, very unfair that non-medics are not having to do that, and that's the situation that we've got just now. And I totally agree with the working with the cabins, etc. There's some amazing businesses, absolutely amazing, but I think we need to have certain procedures in certain premises that are overseen and regulated from our perspective as well.
And my final question, do you believe this bill will provide, because we heard in panel 1 that there is no mechanism for recourse, do you believe this bill will provide people with a mechanism for recourse if something were to happen? And if not, what would you do?
Yeah, I would say not at the moment, the way that it's sitting at the moment. I think it needs some kind of meat on the bones with it. And it's just about giving the non-healthcare professionals this accountability. I think that is going to make, and I think the panel previous to us would totally agree with that as well, that we are wanting it to be a level playing field across the board here. So having that accountability is going to make a massive, massive difference. But I think we need to work on what's here. This is, as I said, it's fantastic. It's a great start. We just need to make sure that everything is in place. The training, the education, the premises standards, the observing supervision, etc., just needs to all be very much succinct and part of this as well.
If you could write to us with just your suggestions.
We absolutely can. We can. You'll be sorry you said that.
Brian Whittle.
Thank you, Convener. Good morning. I've just got a question out the back of the previous panel, and listening to them, it seems to me a concern around collection of data, or lack of collection of data, especially around any complications that may have arisen from any kind of procedure. If we as part of this bill developed a system where we collected that data and deployed that data properly, would that not in itself help to develop a system where those operators who are operating a really good business would be highlighted? Would we be able to start to weed out those ones that are giving the system such a bad reputation at the moment? It seems to me that there's a real lack of collection of data.
Yeah, I think there absolutely is a lack at the moment. I think because there is no need or no requirement to do it from a legal perspective, that's why it's not being done. And I think that it should be a matter of good practice. However, that's not what we're having a lot in the industry at the moment. So I think that if that were to be part of a mandatory requirement, then I think it can only help over the years for us to build up data and for us to be able to assess really as well who should be doing what, where should it being done, and let's look at patterns to see what is going wrong. We do very similar with insurance for the lower level modalities, like what Emma said about waxing, etc. Now we do notice that there is a correlation between people that do not have regulated qualifications and claims. And it's higher for people that have not got the regulated training. We now don't insure them, so we don't get to see that data as much, but our claims are down because we only insure people who are properly qualified.
Okay.
I think we know at the moment that the NHS has to scoop up and deal with a lot of complications and problems that arise from things going wrong, but that at the moment there's no single reporting system for making sure that they're all reported in the same way, so they could be presented if they come in through A&E as 3 or 4 different kinds of reasons why they're coming in for that. It wouldn't necessarily be recorded as something necessarily definitely to do with aesthetics or non-surgical cosmetic procedures. So that in itself is an issue. If we could have some kind of universal system for recording in that way, but then we know a vast majority of complications, they either go back to the practitioner, or if they don't want to go back to the practitioner, they'll go to somebody else and ask that practitioner to fix them, essentially. And there's a real reticence in the industry to fix somebody else's work, and I know that probably happens in the health profession as well, in the private sector. So yes, we definitely need a much more universal system for how we track and deal with those complications when they arise. But it's also important to say, and I'm not trying to be a defender here, but some of the complications that come aren't as a result of negligence or fault on behalf of the practitioner. Sometimes it can be that the person has an allergic reaction, or they haven't disclosed certain information, or various factors. And so it's not necessarily a reflection of incompetence of the practitioner.
but you'd be able to record that as...
Yeah, absolutely. The more data, the better, don't get me wrong. The fact that we haven't had data has meant that we've been able to kick the can down the road for many, many years in this issue. And I think it's something that we recognise and have been pushing for many years as something that we really want to push forward with regulation. And the fact that we haven't had that data has made it increasingly difficult.
Patrick.
Thanks very much. Victoria, you mentioned earlier a difference between the regulations that are going through in England and in Scotland. And I think certainly I'm sympathetic to the suggestions that you're making about how we could make the proposals for Scotland more robust. There's obviously other differences, so I just wonder if you could give us a thought about the other differences where you think we're getting it right, or is other things from the UK system that we should be looking at?
I think where Scotland are now is a kind of where the UK was with the Health and Social Care Act back in 2022, where they put in the secondary legislation to give the Secretary of State powers to bring in a future licensing, blah, 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 blah. That's kind of where Scotland is going with this bill, with a few slight changes. But what's missing currently within the bill in Scotland is that secondary section. So in the consultation of this, in regards to what was going on in Scotland before, we had this group 1, 2 and 3. And that made it really, really clear. What we're looking at in the bill is basically kicked that out of the water. The Schedule 1, 2, groups 1, 2 and 3 don't exist now. And as a result, we have the much more common, much more widely being done, lower level procedures currently having no level of regulation under the proposals within this bill. And what we've been fighting for years is a licensing scheme. The enforcers, the people that work in environmental health, trading standards, etc., are crying out for regulation because they know that there is dodgy practices going on in their local authorities, and they currently do not have the teeth and the powers to be able to close those people down. And so they have been coming to us saying, please help us. We have been going to the government and saying, please bring something in that gives them better enforcement and prohibiting powers. And the moment we don't have that, and my worry with this bill is that, yes, we absolutely welcome that those high-risk treatments need immediate action, and it's good that we're moving in that space, but if we haven't dealt with that secondary part, which has significant volume and people having those procedures every single day and things going wrong in that is going to be able to continue to take place, and that's a concern of mine.
Are you able to tell us what sort of procedures you're talking about that won't be regulated by this legislation? But
so it's all of the is it
the peel, skin needling, radio frequency, non-ablative laser.
Yeah, heat and cold.
Yeah.
I could send you a list after.
So I think that'd be useful.
Yeah.
I mean, I think we thought some of those things were covered, so it'd be useful to know what you think is not covered.
It's more of the, so in England, they, of course, it's going to be different, but they do a red, amber and green. So they have procedures within green where you still have to have a licence, but there's not a supervision element of that. At the moment, there's no provision within that, within what Scotland's proposing here. And there's certain lower level amber treatments in the England regulation that isn't in this bill at all. And that's where we talked about supervision earlier, that we can't, in our opinion, you can't have a one size fits all when it comes to supervision. There's going to be some things that require a person physically in the room overseeing a procedure when it takes place, compared to something which is much lower risk but does still require some level of supervision. And that just might be a listed person that can be on the other end of a phone should something go wrong.
So it'd be really helpful if you were able to kind of write to us highlighting that.
More than
and
happy
probably
to do
easier
that.
for us to digest. Leslie, did you want to add anything else about the kind of differences the two systems?
No, I think Victoria's the policy person. You're very good at deciphering all these.
Which you probably would say anyway. It's that there's no stipulation within this about what the education and training should be. And we can say, until we're blue in the face, that a Health Improvement Scotland premises can only offer these certain types of treatments, but ultimately there's still going to be non-healthcare practitioners potentially offering these treatments with supervision, but there's nothing to say that that person has to have a regulated or accredited qualification, what the supervision and training requirements are of the person doing the supervision and oversight. So just because a person has been an optician or a chiropractor or a, what was the osteopath, they shouldn't necessarily be able to oversee botulinum toxin injection. So they have to have the correct level of training for the modality.
I think that's really helpful. You've put that on the record. It's something that, again, we were talking to the Bill team
earlier. It's very, very important that, you know, whilst we want everyone to have access to be able to train for these different modalities and treatments, you've got to have the prior knowledge in order to do the stepping stone to do so. So I think, just as you said there about an osteopath, their path should not be the same as another medic should be to do it, and the same as it wouldn't be the same as a beauty therapist, because we would need to do more anatomy, etc., in order to get us in the place. To be able to perform these modalities. So I think that's really, really important. But also, conversely, from the medical point of view, that we don't agree that somebody, just because they're a doctor, should be able to do skin peels after half a morning of training, when we are asking that, you know, that there's a regulated qualification in place in order for the beauty professionals to do it as well.
I mean, I suppose some of the detail that you're asking for might be things that could come in secondary legislation or in regular, other guidance, but it's useful you put it on the record, so thanks so
And
much.
if you're going to do that, we really need a clear timeline of when that happens, because otherwise this will be flawed. You need at least an understanding of those things are going to come by X and some kind of commitment in that space, otherwise they're kind of pointless.
Yeah, thank you.
Brian Whittle.
I think some of the questions I really wanted to ask was around how we regulate advertising. That whole idea of what the demand, what is the driving for the demand in non-surgical procedures, being realistic about potential outcomes, especially among the younger generation, I think. And how do we regulate the advertising? How do we make sure that there's potentially mental health issues around there? And I thought it was really interesting in the last panel, because they said, that as part of training, that would be taken into account.
Of proper training.
Proper training, that is taken into account, and there are those operators out there that are operating exactly the way they should be. Yeah. Ethics is, not a black and white. No,
I think it's very, very important. When I did my training over 30 years ago, when I was in primary school, obviously, that was very, very much indoctrinated into us about body dysmorphia, about ethics, about standards. It was just so important. Now, with the inception of 1- and 2-day courses out there, they're just very, very quick. They're very much just get in, learn how to do the treatment, and then back out again, because people are wanting to make money very, very quickly. So we are not getting as many ethics in a lot of the non-regulated training that's out there. I think from the advertising point of view, to bring it back to your original question, with the growth of social media, TikTok, and everything that else is out there, all the different social channels, we are getting unrealistic expectations out there, especially young girls. It really, really worries me of what their ideal of beauty should look like. And it's all filtered. It's not how actually people look, but they think that that's what they've got to look like. It's raising mental health issues. They are going to get treatments done, and unscrupulous practitioners are actually giving them treatments and they don't need it. So I think that a lot of the blame does lie with the practitioner as well, that they should be able to say no and not do a treatment that they did not think that was right for the client, patient, whoever it is that's in front of them. But I think the social media has got a lot to answer for. I know the advertising standards, you're not allowed to advertise wrinkle relaxation injections, botulinum toxin, because it is a prescription medication. But for fillers, because they are a medical device, yes, you actually can. And I think that there needs to be some oversight in it. I don't know how we do it. So, but I think that, sorry. I
think the issue that we have is that the ASA would argue that the regulations that they're already trying to do this, but we know at the moment it's essentially reactionary rather than anything proactive. That when people do advertise things that they're not allowed to do, there's very little recourse. There's not very short level, low level banning for maybe a couple of weeks or something like that. They're asked to take the post down. They're given several warnings. First, I think you need a much more robust system that there is penalties for misusing advertising, putting advertising up that's unsuitable, but also greater penalties on the social media companies that ultimately, I don't know if you've been through your feeds recently, you're an avid Instagram user, but every other post now is an advertisement. And so the accessibility and the visibility of advertising now is so much more prolific than it was even a couple of years ago, that you are unconsciously ingesting all of this information all the time. So it comes back to what Leslie was talking about, how whether you realise it or not, the advertising is going in. Like you're being influenced by it, and the fact that we'll watch there's a lot more reality TV out there than there was previously. It means that these unrealistic body images are being projected by people that generally go on these shows, and then they're subsequently selling or promoting these products throughout their social channels afterwards with, again, very little checks and balances that they are saying the right things or doing things correctly. That's technically advertising as well, but just because someone famous is doing it, it's not necessarily seen as that.
But I think in that respect is why it's so important that the practitioners are held to a high standard, because they're ultimately the ones who can say yea or nay to that procedure. So I suppose then it's a resource issue. And it's all very well saying, here's the standards we want you to stick to. How do we enforce that?
I was going to say that this can be self-funding as well, because if we've got a licence scheme in place and there's a charge for that, that's going to raise revenue, and hopefully some of that could be pigeonholed for the advertising side of things, because I think, there is a lot of false claims out there. But I think just remembering more awareness to what can go wrong needs to be communicated to people out there as well, because I think people do not understand what can go wrong, that you can go blind if a filler goes wrong, you can lose your lip. I've got some fantastic photographs that I show to friends when they're going to go and get things done of somebody with half a lip and it's all kind of melted away. Show that to somebody before they go and get a procedure, then they are going to think twice about who they go to and go and get it done, just because they've seen somebody, advertising it for £50 on TikTok or whatever. I think it's just really, really important to educate people in what can go wrong.
Well, you've certainly made so I'll think about it twice before I get my lips done. Convener.
Aaron Walken.
Probably have answered some of the questions that I had. It's really around training and competency. But just to be clear, there are voluntary standards we've been told that support regulation and improve safety. Do you think that is the case, or do you think that we need to have mandatory training, qualifications?
100%. We are self-regulating as an industry body. We have now decided and taken a massive commercial decision of we won't insure you unless you have a regulated qualification. But unfortunately, just because we're not doesn't mean to say everyone else is. And most insurance companies are commercial. You don't need to be insured to carry out a lot of these modalities. That needs to be, set in stone, that you need to be insured. That's very, very important. But I think that with all of this, that you don't need a qualification to be insured. You can just get out there. You can go and do one day's training and then be out practising. So you could be working in the bank one day, the next day you can be doing some quite high-level treatments out there. So this is what I would like to see going away. I think one-day courses, accredited training is so, so important for our industry, because our industry is ever-evolving and we need to continually develop. So what I always say is that you need the base. You can't build a house on sand foundations. You need the regulated qualification there, and then to build on that, that's where your accredited training and add-ons and everything is there. Just because you've got a sparkly certificate doesn't mean to say that you're actually qualified and able to do a modality. Everyone laughs when I say all that glitters is not gold. It's walking into a salon, seeing certificates up there, oh, they must be good because they've got a nice shine certificate. This is why we need regulated training, Ofqual, SQA, that there is a benchmark there, national occupational standards, it's all set in stone. At least we have then got that benchmark that people have got to adhere to. Some of the accredited training is fantastic, it really is. However, it's not got the same oversight there, and we just can't monitor it to the same level. Very, very important as an add-on, but not a standalone.
And I think just building on that, the regulated qualification is important, but also is regulated or approved providers. Yeah. Because, yes, you could have as many voluntary registers as you want, but if there's no legitimacy or competency from the provider, then really it's not worth the paper it's written on. And we've seen a proliferation of all kinds of training providers put themselves out there and essentially prey on people that, as has been mentioned previously, have limited income and are in good faith going and taking a qualification that they think will then make them fully competent in 2 days in injectables. Absolutely not. There's a reason why the course is taking 4+ years, is because you need that time, experience, levels of competency, discussion on safety, risk, anatomy, etc. All of the things that all encompass. There's a reason why it's taking that long, but yet they're being sold a product for £5,000, however much, and are taking that and saying, well, if somebody's with, you know, these numbers after, these letters after their name are saying that that's okay, then that means it's okay. And unless we have something from the Scottish Government that says, no, these are the only providers that can provide this, or only people that are offering this particular type of regulated qualification can be a training provider, then unfortunately we're just going to continue a situation where we've just got hundreds and hundreds of different training providers.
And it's the use of certain terminology as well. We're seeing it a lot just now, the use of the word level. We, as an insurance company, constantly get people sending in their certificates for us to insure them with level 1, level 2, level 3, level 4, level 5. And when we check, it's just the play of words. I would like to see the terminology that's a protected kind of phrase for education. Also, the use of the word qualification, that is my biggest bugbear. That a qualification is something that is a regulated training, etc. I would say that an accredited training is not a qualification. And I always say that to people when we're discussing. They say, oh, I'm qualified in this. Well, no, you've done a training in it and you've done a course and you've attended a course. You don't hold a qualification in it. And I think it's just getting that terminology out there is really, really important as well. For the consumer as well, we had an event actually at Parliament, you were there at the beginning of the year, up here, just about consumer awareness, because we need to educate the consumer in what they've to look for as well. I can send you all details on that as well.
That's great, that's lovely, thanks. All my questions are answered. Thank you, Convener. Thank you.
Carol. Paul Sweeney.
Thanks, Convener. Thank you to the panel for coming today. Just want to touch on what was discussed in the previous panel around this kind of tension between a level playing field for consumers and confidence that the services are of a certain standard and the barriers to entry for smaller independent home-based businesses. What is your view on that balance, and how could regulation be implemented without disproportionately affecting smaller players in the market?
I think it goes back to what I was saying previously, around being certain premises that are suitable for the levels of treatments that we're talking about here. The higher the level of risk, the more likely it is that that needs to be taking place in more of a clinical environment. And so unfortunately, whilst I completely welcome the ability for people to diversify and offer treatments and services in their homes and mobile, whatever, if they're doing so in a way where they are fully qualified and in the provision that they're undertaking, there are still certain treatments, in our opinion, that shouldn't be being given by those people. And as I said before, there are still a plethora of other treatments that they could offer that fall within the range, within the qualifications that they will have received.
Would you be able just to go into a little bit more detail of what that split should be, and what the hierarchy of treatments might be in a certain setting?
Well, I was going to say that one that we are continually trying to advocate is that anyone who is performing a treatment should be able to manage their own complication, or they have the person in the same building or with them. I know that it has been cited to have the prescribers that they can be a phone call away, etc. But you can't account for traffic, an accident, a puncture in your car on the way to clinic or whatever. So I think for us, for the higher level modalities in the more clinical setting, if you have the correct qualification, you have the correct oversight, then it's fine to do. Can you do that working from home or working from mobile? I don't know. At the moment, I would probably say not. I think it's just important. I did say earlier, again, everyone to stay in their lane and to do what they're able to do and what not is comfortable, but I think the correct clinical settings are very, very important. And to go back to the point that I did make at the very beginning, if we're asking the healthcare professionals to pay a large licence fee to be covered by Health Improvement Scotland, and they've got to tick all the boxes, etc., other people doing the same modalities need to be following the same levels of enforcement and oversight as well.
That's helpful. I just wonder if there are mitigations that could be designed, such as support for training, so that individuals could develop their skills to meet the regulatory requirements that would be introduced. Also, the issue of facilities, which has been discussed in the logistics, whether there could be access to common clinical space, a common user facility, how that might be actually developed, and
Yeah.
what's your view on how that could happen? And it's one thing to say it would be a nice idea. How do you actually?
Yeah, but
create the incentives?
there's no reason, well, please correct me if I'm wrong, but there's no reason why a cabin in somebody's garden, can that not be an HIS clinic as well? You know, so there's no barrier there. I think it is just having the correct standards for everyone. You know, we're asking for parity, but it has got to be parity across everything. You know, we can't have it always. I think, you know, it's got to be there. But I think that everyone should have access to the training. I know that what we're doing just now, we're working for for skin needling, skin peels, laser, etc. We're working with a number of colleges to do some sort of shorter training, but just to be that maybe you would go to a centre, be assessed to see what your competency is, see what is missing from that in order for you to gain a regulated qualification, and for the person to only have to do that so that they're not going to have to retrain. You know, there's a lot of very, very good operators out there just now that have maybe been doing these modalities for 10, 15, 20 years. To ask them to go back and retrain to get a certificate is probably quite onerous. However, we've got to be assured that they are meeting that national standard. So there is ways of doing it. We are working with centres just now to make that transition much, much easier for people from a financial, from a time perspective, because a lot of people are working full time. We did hit on that this is a predominantly female industry. I think the survey that you did a few years ago, Victoria, 88% female workforce in the UK wide and 80% business owners are female in the beauty industry. So it's important that we support that, but safety must be of paramount. We've got to ensure that the safety is there.
And I was just going to add to that, sorry, that I absolutely do have sympathy that there should be a route to get the professional level of standard of qualification to be something like a prescriber, for example, without having to accumulate, and I know it's slightly different in Scotland, but several hundreds of, potentially tens of thousands of pounds worth of debt if you're not practicing, going to university in Scotland, if you through going through a healthcare practitioner route. And so I would really like to work with the regulators, government, etc., to look at ways where we can find a more accessible route. Yeah. But and as it currently stands, a level 7 is meant to be a master's level. Yeah. Master's level qualification, but I do still think that there needs to be additional mitigations in place to ensure that there's more of that clinical level of safety, which ultimately we're not experiencing every day necessarily in a beauty professional environment.
No. And I think that's really, really important to see how we can get everyone to that level, because what we don't want to do is be encouraging people to go and do a nursing degree only to then leave and come into aesthetics, because then there's the burden on the NHS of paying that and then not getting the benefit of it. So I think if we could work together and do some sort of aesthetic nursing training, that they don't need to go through the full medical degree of being a nurse, but going through all the very, very important parts in order to manage complications for all the different modalities that they'd be doing as that aesthetic nurse.
Do you have a view on potential unintended consequences of the legislation, particularly around driving behaviour underground into an unregulated space or even overseas or to different jurisdictions, even if there's a difference between Scotland and England?
Yeah, I think that's why we need parity between Scotland and England. It was very apparent during COVID when we had, I think we called it Maskgate, that in Scotland, obviously, you were wearing masks a lot longer. England, you weren't. People were going cross-border for treatments. So I think if we can avoid that as much as we possibly can and have as much parity there, that would be really, really good. I think we're never going to avoid driving people underground. I think we are. But I think as long as we can make things as robust as possible to make the enforcement fair but firm, I think that's very, very important as well, that we would get a lot of buy-in from it. And I think people would train. I think people fundamentally want to do the right thing, most people anyway. Yeah. Hopefully.
It was just very quickly, Ms. Brilling, you mentioned about this kind of idea that certain treatments you don't think is appropriate in certain settings. Can you just give us a couple of examples of what you're talking about, just for my own clarity?
Sorry, repeat that one. Can you just
You
repeat?
mentioned in your initial response to my question certain treatments you didn't think were appropriate to be carried out in, say, a home setting. It was just, could you give me some examples of what you're talking about?
Yeah, so injectables would definitely be within that, anything where we're intravenously injecting. So there's been a massive surge in kind of vitamin injections. If you're hungover, go and get a vitamin injection, or weight loss injections, which are administered by a clinic practitioner as opposed to by the individual themselves. Those kind of, anything injectable based, I personally just don't think should be done anything other than in a clinical setting.
Okay, thanks.
Patrick Harvey.
Thanks very much, convener. Good morning. Just about morning still. Good morning to witnesses. I wanted to come on to the equalities impacts. A number of questions on this, which I discussed with the last panel as well. I think a moment or two ago, Leslie Blair was talking about the number of women-led businesses that are in this industry, and followed that up very firmly by saying, but safety is paramount. So I'd like to explore that balance a little bit. The last panel were quite clear on the positive opportunities for people providing these services, and in relation to wanting to ensure that there was still access to these services. It was a little bit more difficult to draw out from the last panel some of the disproportionate risks and harms that particular groups in our society might face at the moment. So could I ask if you agree in principle, first of all, that a completely deregulated free market approach to this issue would reduce the inequalities of business opportunities, and it might reduce the inequalities in terms of access to treatment, but it would massively exacerbate the inequalities in terms of harm and risk? And how do you feel or do you agree with the government's position that this bill strikes the right balance in terms of mitigating some of the negative equalities impacts, but the government's view is that the positive equality impacts from the bill outweigh those that are negative?
I think for me, I'll come back to safety must always come first. I think that's got to be our first decision in anything that we do. And I think Victoria very eloquently went through about if you have trained throughout the different levels, there's lots of different things that you are able to do. We are not advocating at all that anyone is not allowed to do anything. What we're saying is make sure that everyone is trained to appropriate level and qualified to an appropriate level. And that might be that if you are wanting to train in injectables but you don't want to go down the medical or the healthcare route, then you're going to have to work with a prescriber. If you don't want to work with a prescriber, then you are going to have to go down the medical route to become a prescriber, etc. So I think there is absolutely no barriers there from restricting any training to anyone. So I think that what we need is, again, going back to the beginning, we need a level playing field. We need everyone to be qualified in the modalities that they're doing and be proficient. And I think that then means it's open to everyone in order to go down that route. And especially when we're talking about people upskilling from what they're doing just now, if they're not holding regulated qualifications, there is pathways that are going to be in place. We're working on that just now. People are doing it just now already, actually, in order for them to gain the qualifications. So I'm probably talking more about the level 4, the skin needling, the skin peels, the laser, etc., which we do really, really hope that there will be a regulated training requirement that operators would hold when conducting these treatments.
Thank you. I was just going to add that I think the accessibility and availability of these treatments has absolutely exploded over the last decade or two, specifically. And as a result, the regulation or lack of, as it currently stands, just hasn't kept pace with the proliferation and availability of treatments, and it changes every year. Some of the procedures that we were talking about even a couple of years ago when the works first started here on types of treatments that should be considered within scope has moved on greatly, and I should imagine it will do again in the years to come. So for us, there is a responsibility there that, yes, there is issues around whether what's going on in the bill is proportionate and whether it will affect people in a more positive or negative way than others. But because of this accessibility and availability issue, we found that there's now a huge influx of people offering these treatments because they have seen a really easy and accessible way to make good money and careers out of offering these treatments. And a lot of people, I should say, and have said previously, are doing that with great levels of training and competence and are having very few at things go wrong and such like. But there are also others that are taking part in essentially a race to the bottom, a race to cheap prices, and they're in competition with each other because there is just such greater accessibility to providers now than there was 5-10 years ago. And that ultimately risks vulnerable adults, especially young adults, who are very impressionable, who are essentially being sold services without the correct oversight and checks and balances on them to check that they should be having those treatments, that they understand the risks, that they understand the alternatives, and they look at whether they even need these things in the first place and the deeper reasons behind why they want them, the affordability of whether they can afford them in the first place. I mean, we also see situations of people taking out credit cards and loans and taking on debt in order to fund the proliferation of these kinds of treatments. So for me, that risk far outweighs the potential negative effects that could come as a result of restricting the availability to offer these treatments to certain groups of people.
I obviously don't want to put words in anybody's mouth, but I think it sounds as though both witnesses are saying that the equalities impacts are leaning more toward the positive than the negative from the bill as it stands. The last panel did make, well, at least one witness made the suggestion that there are some additional issues, for example, in terms of seeing people who have perhaps language issues or accessibility issues in terms of the information provision that's available. One of the witnesses suggested that there could be improvements there that would mitigate any risk of disproportionate harm to people in that category. I'd like to ask for reactions on that, first of all, and then I'll come on to the issue of age as well.
I actually think at the moment the information, I mean, Leslie's organisation, Babtak, does a great campaign around trying to educate people to simplify the messaging around this. But I actually think the bill is beneficial to those types of groups of people that you were discussing, Patrick, because it's going to hugely simplify. This is what is safe. This is ultimately not a safe route for members of the public in a way that just does not exist currently. So we were discussing kind of this wild west, and it sounds dramatic, but ultimately it is essentially a bit of a Russian roulette when you go and have these treatments or go and inquire about the treatments as to whether or not you're going to get a safe procedure or not. And ultimately what this bill is setting out to do, and as I've mentioned, it does need some work, will go some way into improving that level of understanding from the public of, if you want to go and have any of these treatments, this is the avenue to do it that's a safe route.
Yeah, I agree with what Victoria said there.
Thank you. And if I can finally come on to the issue of age, there does seem to be a broad agreement, a broad welcome for the limitation on an age limit of 18. I don't hear any dissent from that. But from one or two of the other comments that I've heard, that there's perhaps a question mark about whether any additional safeguards are needed for younger adults, people who are over 18, who are adults, but who may, for one reason or another, be particularly vulnerable to pressure, to kind of social media influence, to coercion, to some of the social pressures that exist that may drive people to access these services for perhaps the wrong reasons. Now, if we were talking about healthcare, I'm a very strong advocate of Gillick competency and those principles that young people, including those who are not adults, their competence to understand decisions about their own lives needs to be respected on an individual basis. But we're not talking about healthcare here. We're talking about buying services. And I'm personally kind of resistant to using the term treatment, which kind of implies that it's treatment for a condition. These are services on sale, on a commercial basis. Is there the need for any additional safeguard, do you think, in terms of younger adults or other groups who may be particularly vulnerable to those pressures and social influences?
I think we would need to lean to the operator practitioner to be able to be governing that. I think that there is a definite need for an age restriction for at least 18 for anyone going to get any of these treatments, unless obviously it is for medical, and there's many other reasons to have the kind of not aesthetic side of things. But I think that we have got to allow the practitioner to be able to assess that when they have the client or the patient, if is a medical provider, having them in front of them. I think they've got to be given that oversight, I think, to do that. I would say I think it'd be very difficult to manage. If not, I don't know how we could quantify it. I don't know how we would manage it. I think that that's probably something in the standard of training. I think that we maybe ensure that I think it's probably already there.
Yeah,
the body dysmorphia and everything, and I think just to make sure that that is part of the good practice. Sorry.
I was just going to. Sorry, I'm coughing for you. I was going to add to that and basically go over what Leslie mentioned earlier, which was around the difference between a regulated and accredited qualification and short courses. Technically, somebody that's had a regulated qualification, and you with your 30 years experience, they will know things that should be mandatory within any consultation period for someone wanting a service, as you mentioned. And that should be things like a cooling off period, going over risks and potential effects and things that may not go the way that you want them to go. And all of those different things should be discussed with the client, the patient, before they're going to have the treatment. And then there should be at least a 24-hour period, if not longer, whereby that person can go away. They're encouraged to look at and to speak to others, to talk it through, look up and do their own research before then going back and having the treatment. It shouldn't be that they come in and they have the ability to have that treatment straight away. That should just be par for the course for people that are operating reputably currently.
The higher level modalities, for sure.
Thank you both. Thank you, Convener.
Thank you.
Elena Burton.
Thanks very much, Convener, and good afternoon. We only have a couple of minutes left, so I'm just going to quickly run through a few questions round about enforcement and compliance. And the first one that I have is, do you foresee any practical challenges that the aesthetic industry might face in meeting the bill's requirements on inspections and compliance?
At the moment, yes, because I think that, for example, environmental health they're very low in resource, but hopefully if we had a paid licensing scheme, we could raise the finance in order for us to fund it and to be self-funding. I think that's where industry bodies like ourselves and British Beauty Council would really be happy to work with, and we do work with environmental health just now, as it is with a lot of their governing body, in order to give advice and to help support them. And I think it's just ensuring that they are given the correct enforcement powers, and as I say, it needs to be quite strong to make people stick to it and to make sure that they know what they're looking for as well. I think that's very, very important, because that's what we hear all the time from environmental health. I don't know what I'm looking for. What is a qualification? What is a certificate? So we can definitely work with them for that.
I also think that Health Improvement Scotland have a responsibility to be part of that successful enforcement process as well, and the rollout of that. In the same way as in England, the Care Quality Commission have the responsibility for those more high-risk procedure, kind of the regulatory oversight of that. I think if we're saying that a Health Improvement Scotland premises is deemed to be a safe premises because of the practitioner qualification, because of the fact that they are inspected, etc., then they should bear some kind of responsibility for the oversight and supervision of that then feeds into this work.
Okay, that's very helpful. And in terms of the bill as it's drafted, do you support the offences and the penalties that are currently proposed in the bill? Or is there anything that you would seek to change within that?
I support what's in there currently, but I think it just goes back to what I said before about the licensing need for those other kinds of treatments as well, the lower risk but still require some level of licensing and oversight. Yeah. And at the moment, the complete lack of provision within there for a license means that ultimately those people are able to continue offering treatments with little to no recourse for the consumer should something go wrong, or a degree of sorry, I've completely lost my word. We talked about this yesterday. That the client will know that that person has the correct level of qualification, that their premises have been inspected, and that they're ticking all of those boxes.
Yeah. Okay, and where we do see breaches under the legislation, do you feel as if there needs to be a level of improvement notices, education, working towards compliance? Obviously, if breaches are of such a standard that they are, you know, needing dealt with.
It's going to be proportionate. It's got to be proportionate. Can I just go back slightly, though, when you were talking about the licensing side of things? I think where that is so important, there's so many modalities that have got different levels of what they do. For example, skin needling, skin peeling and laser. For a beauty professional to do certain levels of skin needling, skin peeling and laser is absolutely fine. If you've reached a level 4 qualification, you are more than able to perform these treatments safely and to manage any after effects of that. It does need to be proportionate, though, because skin needling can go deeper, peels can go deeper. We can get that it's more, the laser can be ablative and taking away a lot more layers of the skin, etc. And this is where we need just a whole approach of the licensing leading into the HIS oversight, so that we can all work together. But as Victoria so rightly said, at the moment, we are not going to be able to kind of hone in on the levels that we should be doing as non-medics and doing safely. At the moment, that's not got any oversight on it just now. So you can be doing the deeper peels, you can be doing the skin needling, you can be doing the laser. So that's where we need to be working on as well.
Okay, so should there be an even playing field in terms of, we think about a tattoo artist and a tattoo studio having to be licensed versus somebody that's operating a laser to remove said tattoo?
Miss Whittam, there is actually a licensing scheme coming in parallel with this bill.
Okay.
Yeah.
That's very helpful. Thank you.
Thank you.
That answers my question.
Just in case we went off. Was there anything else you wanted to add? No.
We're out of time.
And so we have one final question from Sandesh Gohani.
Convener, for getting me in. In the previous panel, we were speaking about young people, and Louise said that her business would not do anything for anyone aged under 18. So did a few other panellists spoke about 18. What's the correct age for you and why, given people can vote in Scotland at 16, given the law talks about different sentencing for under 25? So what is the age that you think is appropriate?
I think you may feel differently here, but I think 18 is proportionate, because we're also looking at the way that our bodies are developing as we move into adulthood, and I think 16 is still too young to see how your body is developing and changing. Potentially you could say that it will continue to change into 21, etc., etc. But I think if we're wanting the parity with the UK, we were very instrumental in pushing through the legislation which restricted injectables for no one under the age of 18 back in 2021. So we would want parity with the UK in that respect.
Agree, 100% 18 for all the same reasons, and I think as well for enforcement, and I think for people sticking to it as well. I think that we'd get an awful lot more buy-in with that as well, rather than people can be married, they can buy a house, whatever, at that age and below. I think to then say that you can't go and get a treatment till you're 21 without parent consent, or you can't have it, I think would be overkill, to be honest.
Thank you.
Thank you. Can I thank the witnesses for their evidence this morning? At our next meeting on Tuesday, the 9th of December, the committee will continue its scrutiny of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill, taking oral evidence from 2 further panels of witnesses. And that concludes the public part of our meeting today.